Thank you. And I am sorry about being late. I just not late, but be in the wrong place. So let's get started. So this talk is heavily biased. I'm going to talk about cannabis, ketamine, catatonia, criteria, and controversies. We're going to touch on all 5 of those things. None of these things are brand new. I assume that all of you know something about all of what I'm going to talk about, but hopefully there's something new in each individual area. This is heavily biased by my work. I primarily work on 5MB, which is psychiatric ICU. If any of you have been up there, essentially what I deal with is psychosis, delirium, catatonia, and this general agitated behavior, and that's what I do all day. We have certain slogans on 5MB. If you're talking, you're walking, which means once you're able to communicate with me, I send you to the other units where you can kind of do other dispo planning and work more with folks. So we deal with psychosis a lot, and that's heavily biased is what I'm talking about today. So cannabis, starting off with cannabis. I think Washington State is clearly in the midst of a big experiment about the safety of cannabis, and what will happen is really unknown. This comes from just a review from a couple years ago, the Nora Volkow and collaborators put together in the New England Journal, and it shows in blue on the top the essentially the past year use of marijuana, and red is the perceived risk of marijuana use. And I only show this because clearly the perceived risk, they're kind of mirror images of each other. And also to point out something very important, which is this year right here, which is 1992, which is the year I graduated from college, which is at the all-time low of cannabis use. And I just would like to attest that, yes, cannabis was not used openly. No one smoked it. I was a president of a fraternity at MIT. No one smoked it in the open. It was a behind closed door thing that happened only if you really looked into using it. So it was kind of a very odd time, according to this chart, and I would attest to that too. What's more concerning, I think, is this lower chart, which shows the daily use of both cannabis and nicotine. The blue line is nicotine, the red line is cannabis, and it shows that as nicotine keeps going down in 12th graders, we see increased daily use of cannabis up to close to 10% in 2013 by the recent data. And this is concerning. Why is this concerning? Well, here's a case that we had about a year ago now. A 20-year-old college student presented with acute on subacute decompensation. Essentially, he was a sophomore in school and hadn't been attending his spring semester. This included extreme paranoia, auditory hallucinations, and the belief that the world will end. He was admitted to an outside psychiatric facility, and 24 hours after admission, he had enucleated both his eyes with a pencil. I'm happy to say that about 2 months afterwards, I got some follow-up that he is getting a little bit of vision in one eye. At least he can see shadows. He was stabilized at Harborview for a couple weeks on olanzapine. He was actually quite calm, considering what had happened. He's actually basically in shock, I think. Not just physical shock, but sort of mental shock about what had happened. And about 2 weeks into the admission, we were able to talk with him. And what he really talked about, we went through all the substances and all of what was going on. He was using cannabis excessively. Basically, what he was doing is getting green sick. And green sick, if you Google it, green sick is usually a term used for first-time cannabis users where they feel a little nauseous, they want to go to sleep. He referred to green sick that 3 to 4 times a week, he would smoke as much dope as he could so he would vomit everything out of his stomach and pass out from the amount of cannabis. He did this basically by dabbing. And for those of you who don't know about dabbing, dabbing is sort of the crack cocaine of cannabis. Basically, you take cannabis leaf, you extract the THC with a volatile gas, usually butane, sometimes propane, and then once you have this resin over there on the left, you essentially put it back into something like a crack pipe and use butane, propane, or something flammable, volatile, to burn it, to smoke it. This delivers THC at doses up to 100 times more potent than a joint, and it really is a very dangerous thing to do. This is very common. We have essentially once a week, we'll have someone admitted to our unit who's been dabbing on cannabis and contributing certainly to their decompensation. So cannabis, this is kind of just a very brief review. There are 2 cannabinoid receptors, CB1 in the brain. It's highly expressed in the basal ganglia and some of the amygdala, hippocampus. And it's also expressed kind of all over in the cortex, highly expressed also in the cerebellum. CB2 is mostly expressed in the immune system in the periphery. There's 2 endogenous ligands, an anandamide and 2-AG. These are both act primarily as retrograde signaling molecules involved, of course, in lots of systems of learning and memory and modulation. The fact here is there's only over 50 cannabinoids in cannabis, of course. The 2 most known ones are delta-9 THC, tetrahydrocannabinol, and then cannabidiol. So delta-9 THC is, of course, the psychoactive ingredient of cannabis, causing psychosis. And if you give it to naive people, it really creates a lot of anxiety. So just like alcohol, where we always think of it as it's a sedative, but yet most people don't get sedated when they drink alcohol. Cannabis is thought of as also being very anxiolytic, but if you actually give it to naive people, it's actually very anxiety producing. Cannabidiol is a very interesting molecule that's also found at relatively high concentrations, but much lower than THC. And it's interesting because it's, of course, being very much investigated for use in multiple medical uses, seizures, pain, and actually treatment of psychosis. We'll talk about that a little bit more. The pharmacologic versions, dronabinol and nabilone, we don't use those at all. On psychiatry, we certainly do have some patients that request them. So this is just right out of the Vocal Review. This is just an indication that, yes, this cannabis that's on the street now certainly is not the cannabis that was on the street before. This is just THC concentration nearing over 10% now, basically, in the cannabis that people are buying on the street. So if this is Cannabis Controversies, does cannabis induce chronic psychosis? This is, of course, the big question in psychiatry. The studies that have, the people who are doing the best job of looking at this are Northern European countries where cannabis has either been legalized or very used and widely, basically, in the population, and they also have good records. And the data would suggest now we have at least half a dozen big primary papers and meta-analyses that have looked at the age of onset and the chronicity of psychosis in people who use cannabis, and it's not good. So certainly age of onset seems to be reduced by several years if you're smoking cannabis on a daily basis, and the chronicity of psychosis, repeat admissions to the hospital, continuing psychosis, even with medications, seems to all be exacerbated by chronic cannabis use. There is some gene exposure interactions that I think are coming out right now that are very interesting as far as related to the dopamine D2 receptors, to COMT, to AKT, which is a serine-threonine kinase involved in lots of signaling pathways. But certainly it seems that these genes may contribute to the risk of psychosis when you are smoking cannabis. And there's a very interesting finding that folks have found elevated anandamide and CB1 receptors in the prodromal phase of schizophrenia. And it's actually been hypothesized that this could be some sort of reaction to ongoing psychosis, actually trying to modulate dopamine activity. That's very much theoretical, but it is an interesting finding that there seems to be elevated cannabinoid systems in folks in the prodromal phase. However, and I just want to show this, those at risk for psychosis are more likely to use cannabis. And this is always what comes out, is the same factors, the socioeconomic factors, the genetic factors, either just straight heritability or some of the gene factors, seem to be also put people at risk for not just psychosis, but use. So the same people who are at risk are using, which is kind of bad. This is kind of what we see certainly in this country too. And blocking CB1 receptors doesn't seem to have any effect on psychosis, just purely blocking.
Is medical marijuana the same as what you got on the street?
Well, it's all different, quite frankly. When you go into a head shop and they have different arrangements, they're actually really trying to push forward this idea that cannabidiol is good for you, that it's an anxiolytic, that it's healthy. So there's 2 strains, sativa and indica, of cannabis that have differing levels of these things. The real issue, though, in America, and we'll get to some of the numbers, is that the ratio of commercially available still has so much THC in it that the levels of cannabidiol probably aren't relevant. So it's a little bit of false marketing. So pharmaceutical companies, when they're making this stuff, are making much, much higher levels of cannabidiol, not cannabis, when they're making a product. So this is just cannabis controversies. Is cannabis usually useful in PTSD? So just to make a statement, the American Psychiatric Association does not recommend cannabis for treatment for any psychiatric disorder. Not as an augmenter, not as a once in a while use. It basically says don't use it. But the PTSD community, really for a number of years, has been seeing a lot of people use cannabis and essentially has been, not, I wouldn't say promoting, but tolerating quite a bit of use. This study came out, this is basically veterans, and you can look at the numbers there. This is over 2,000 people who were admitted to an inpatient PTSD ward, and just looking at outcomes. And the table is kind of too small to read, but just going across it, the starters, people who started using cannabis after being admitted to the hospital, did worse on every measure of basically between PTSD symptoms, violence, alcohol abuse, drug abuse, employment status. Excuse me, that was not significant, but the other things were significant. And essentially, the cannabis use was not good. And the worst people were the people who started smoking. The second worst people who continued smoking the entire time, the people who never smoked, and the people who stopped smoking seemed to do much better. This kind of came out as really sort of one of the best studies of looking at kind of large-scale cannabis use, and really the recommendation was we shouldn't be recommending this. This isn't too surprising to me. We have another molecule in psychiatry that, of course, you guys are very familiar with too, that everyone loves for treating anxiety, benzodiazepines. Certainly everyone with PTSD would love to be on lots of benzodiazepines, or many of them. It doesn't work. It's not a long-term treatment for the disease, certainly. And cannabis is probably the same way. Does it decrease anxiety? Yes. Is it really good for treatment? No. So a little bit about cannabidiol. Is it beneficial in mental illness? So cannabidiol at high enough levels can reduce the psychomimetic and cognitive effects, so the negative cognitive effects that would be of THC. And then this is some ratios here, and it's kind of a little bit much information maybe, but the street ratio currently is around 0.01. Of cannabidiol. So generally speaking, you're talking about 6.9% THC to about 0.1 to various to 0.25 cannabidiol to 21% THC. That would be a very high potency cannabis. This is the thing that's increasing the risk of psychosis. If daily use might increase the risk of psychosis 6-fold. The high street ratios currently are only about 0.5, so cannabidiol is still present in only about half the strength of THC, and there's still a ton of THC. So it's not really that the levels of cannabidiol are so deficient to be beneficial, as much as there's so much THC in this stuff that you can't overcome that. But there are some preliminary studies that suggest that cannabidiol can reduce psychosis. And I also put this in there. If you do a PubMed search, you'll see cannabidiol listed for treating everything from dementias to inflammation to epilepsy to pain. And I think all of this is being developed, certainly. I don't know what stage this is. I didn't look into that. I have not heard any pharmaceutical rep tell me how far along this is, but I know it's being investigated. So finally, just to wrap up, we're seeing a lot more spice use. We've been talking about this in Seattle for about 6 years and not seeing much, but I will finally say that in the last 2 years, we've really seen it at Harborview. Spice is synthetic cannabinoids. They were first synthesized by John Huffman in 1993, and they're not equivalent to cannabis, clearly, because they're synthesized to be slightly different. So initially, the FDA couldn't regulate them. Basically, what spice is it's an herbaceous mixture of flowers, of oregano, of whatever they want to put in this herbaceous mixture, and they spray a chemical, basically a cannabinoid, on top of it, and they package it. The problem is the packaging is completely unregulated. The chemicals are generally either fully synthesized or partially synthesized somewhere unknown to us, and it's basically shipped to America in kind of a very crude form. So that essentially, even buying one brand, for instance, K2 up there in the top corner, if you buy one brand, week to week, the concentrations of both the active and whatever the herbaceous mixture, so there is quite some anaphylaxis by smoking unknown herbs, that you really just have no idea what you're using. And so we're seeing a lot more people who, even if they use it on a regular basis, can use a different product once and really come in psychotic. Typically, some of the synthetic cannabinoids are more powerful, a fold about 10 times more powerful than THC, so are more risky. Ketamine.
Can we
Yeah.
ask a couple questions? I know time's sensitive. Is there any interaction between the age at which you would use a cannabis product and the development of psychiatric illness? We're all worried about young people using this high school age.
Yeah, so that data has not come out yet. Clear data showing that certainly there's data showing that using it young can promote psychosis. The difficulty is that the folks who start using it later on generally have psychosis in the first place. So it's unclear whether it has the same detrimental effects on adolescents, or I should say on adults, that would on adolescents. What I will say is, talking to the adolescents that I have met who use it, they're smoking just an amazing amount of the stuff. A gram of crude dab a day, and it's really, that's what's shocking about it. So we're talking about extreme use, in much the same way we're talking about alcohol as being extreme use when people have chronic problems. Yeah.
Is that dab stuff smooth by recreational?
No. It's street produced, and it can be produced in your own home if you are savvy. We have people who've blown up their kitchens making this stuff. So it's very risky. Yeah. So you cannot buy it. You can buy cannabis oils. And actually, I don't think you can buy resin anywhere, but you can buy oils. They're also very potent, that have about 10 or so times the potency. And I certainly have had a case of a woman who didn't follow directions, and rather than taking a drop, took a teaspoon of it and was psychotic for a week or so. So ketamine, very briefly, ketamine, it's a dissociative anesthetic acting as an NMDA antagonist. I put the little question marks to kind of foreshadow things. It's used in anesthesia, pain management, to promote sedation. It's short-acting. It's generally, depending on if you take it IV or PO or snorted or whatever, it can last for 1 to 2 hours. It is sometimes abused. It's injected, ingested, snorted, and smoked, basically any way you can take enough. And if you look into these drugs, they can all be used in many, many different ways. In 2013, it was estimated that about 200,000 people were active ketamine users in the country. That's obviously very much of a ballpark figure. So this is ketamine, as you're probably all aware, is very hot right now for treating both treatment-resistant depression and basically just general depression. But the amount of data we have is very slight. And so this is a meta-analysis, a meta-meta-analysis that was just published, basically, it just came online about a month ago. And so it's looking at all of the meta-analyses that have already been done on this subject about single-dose ketamine for the treatment of depression. And what I just want to point out on this chart is, if you look down this is response, and then in red down here is remission. This is 24 hours to 7 days. What you can see is the odds ratio for improvement of depression basically goes down. And this is true for remission in the same way. So a single dose of ketamine of approximately 0.5 mg per kg given over 40 minutes IV can certainly and very robustly treat acute depression. The effects last from a couple days to potentially 10 days, but they always seem to wear off. There are now dozens of there's over a dozen fairly good trials showing this. They're not controlled. Generally speaking, they don't have a placebo control. Some have started using midazolam as a control, but even the midazolam control ones seem to show that ketamine is effective and midazolam is not. Here's the problem, is that there's multiple doses are more efficacious than single doses. So clearly if it's wearing off into 7 to 10 days, it's not very useful for long-term treatment. So people are looking at doing treatments 2 to 3 times a week. But those trials have only been for about 2 weeks. That's the only thing that's been published. All there has been is a few case series of longer-term treatment. High dose is somewhat more effective than low dose. It's not too surprising. And there is some suggestion that people with major depression are more responsive than folks with bipolar disorder, but that's very preliminary. But the fourth point down here, which is very important, is there's an utter lack of long-term safety and efficacy studies. Basically, no one has published any quality data of longer than 2 weeks of treatment with ketamine. And the field is really at a standstill because this is a drug that is highly abused, highly addictive, and there's a number of case reports now being published about people who have been treated for depression with ketamine that are then sinking it and buying it illegally and getting into big trouble with it. Up on the top here, the Ketamine Wellness Center is something I stumbled across just after when I was Googling ketamine. They actually market, they say if you're in part of a trial and it helps you, come in contact with us. They're open in Houston and a couple other cities in the country. They employ basically anesthesiologists to give you ketamine. So I pause and wonder where that's going to head. But let's shift a little bit to talk about suicide. So suicide is obviously a big problem. So a little background, there's over 40,000 deaths by suicide each year in this country. There's a great little website if you just search suicide in Washington State, you can actually get these little flashcards about all the data about suicide in Washington State and every state if you wanted to, by the American Foundation for Suicide Prevention. I just wanted to show this because I think it's interesting as a kind of outside of psychiatry. In psychiatry, we're always using subjective measures. This is a suicide scale. This is actually a frequently used suicide scale. It's really simple. This is actually, this is certainly not complicated. Where you just ask someone if they're wishing to be dead versus if they have thoughts about killing themselves, thoughts about how you might kill yourself, some plans and some intention. So when you're measuring suicidality, this is basically how you measure. They're very simple scales. On some of our more complicated measures, like the Beck Depression Inventory or stuff like that, they're basically one question about your suicidality. So more recently, people have been looking at ketamine for the treatment of acute suicidality. And this is very hot. Down at Biological Psychiatry, just a couple months ago, there's about at least half a dozen groups had preliminary data or fairly complete data about ketamine's use to treat suicidality. It seems to work very quickly. So this is comparing ketamine to midazolam, and these are just two different measures of suicidality. Midazolam on the top, ketamine on the bottom. Two things to notice is that yes, ketamine seems to work quite quickly basically this is a single dose of ketamine. But the other thing to notice, of course, is that a couple days out, it's no different from your midazolam control. Now, this is not surprising as an inpatient provider. What do we do in psychiatry when someone's suicidal? We take them into the hospital, and generally speaking, their suicidality is reduced. So, I'm not sure what to really think about this, but suicidality is generally speaking, not a chronic condition, generally speaking. So some issues in assessing ketamine's effects on suicidal ideation. Obviously, ideation does not equal attempt, does not equal death. Most of the trials of ketamine have looked at suicidality as a secondary analysis, not a primary, because they've been enrolling folks who are depressed. The scales are really designed to measure kind of sustained thoughts, like for the last 2 weeks, how suicidal. So if you have like a quick change, you might be missing all of that. And patients are not blind to treatment. So even if you take midazolam as a control, you still know it's not ketamine, generally speaking. There is quite a dissociative component of ketamine that's reported in all of these studies. So just a little bit, never let data stand in the way. So this unfortunate review is not even quite published yet, but it's just looking at complicated ways of how ketamine, being an NMDA antagonist, could be basically inhibiting GABAergic function in the cortex and promoting pyramidal cell generation of BDNF, and very complicated, and I certainly don't want to go through it. The problem is that just about a month and a half ago, 2 months ago, there was a big Nature paper basically saying that the antidepressant effects of ketamine had nothing to do with NMDA receptors. In fact, and so that's actually really good, and that's why this is such a fundamental finding. I'm not sure if this has any, if you folks in neurology are talking about this, but clearly the pharmaceutical companies, once they've recognized this, are now full steam ahead to develop agents that are like this. So ketamine and enantiomers have different potencies. That was kind of known. And basically what they showed is a metabolite of ketamine, hydroxynorketamine, contained all of the antidepressant properties in animal models. And this really was a big surprise, and that blocking conversion of ketamine to HNK completely abolished all of its antidepressant properties. And HNK has absolutely no affinity for NMDA receptors. How H and K is affecting these animal models of depression is a little unclear, perhaps through AMPA receptors, perhaps through other mechanisms. But what's clear is that it has no psychomimetic effects and no anesthetic effects. H and K does not. So agents that are working in the same pathway could be very successful antidepressant agents without any of the problems that ketamine actually has. So this is kind of exciting. And finally, there is one other buprenorphine, and I just kind of put this out as a very new thing. Buprenorphine has been recently reported to have anti-suicidal properties in folks who have chronic suicidality. So this was actually a very big paper that came out looking at fairly low dose buprenorphine. And if you're not familiar with buprenorphine, this low dose of buprenorphine is actually the abusable dose, the dose that makes you feel good, and those sold on the street, unfortunately. But over the long term, and this is in weeks, you can see that in yellow here, buprenorphine reduced suicidality in psychiatric patients with both depression and borderline personality disorder, and helped both those individuals. So that's kind of, it's very interesting, and I think people will be looking into this. Catatonia. I'm wondering if in the time, if you guys want to, you guys see a lot of catatonia yourselves, I imagine. I know you guys call psychiatry to kind of, we'll talk about a little bit about catatonia. So this, because this is a great case. This is like one of the cases that I'm collecting these cases. Unfortunately, my latest treatment has not worked. This is a 27-year-old female involuntarily detained and boarded outside ED. She's basically restrained and treated with IM, olanzapine and lorazepam in alternating doses, not together. For 6 days, refusing to speak, refusing to eat. She was shipped to us. She was mute, staring, lying in bed for nearly the entire day with dramatic negativism. She would try and lie, just staring. I had my colleague attendings who covered on the weekend begged me to not have them see this woman because you just walk into the room and she'd stare at you with such hatred. Even when you, I mean, just such utter hatred that it was uncomfortable to be in the room with her. She'd lie in bed, tracking you with her eyes, and when you moved towards her, she'd just shirk away slowly. She didn't look really stiff, but as soon as you tried to move her arms, she would not allow you to move anything. It was a really dramatic catatonia. We tried lots of things. Of course, she was refusing all PO meds. She failed a 6-day trial of IM lorazepam, a 10-day trial of IM olanzapine, greater than 30 days of IM aripiprazole. We actually put her on long-acting injectables because essentially it becomes inhumane to give people 3 to 6 IMs a day for over a long period of time without any response. She was not responding after 6 weeks. She was bleeding out of her mouth because she had no oral hygiene. She would stand up a couple times a day. She'd get up and she'd use the bathroom. She would actually walk out of her room once or twice a day and ask for food. Where's dinner? The nurses would give her dinner. She'd take her dinner and walk back into her room. This is one of the misconceptions of catatonia. Simple speech, can I have a blanket? Where's dinner? Is not inconsistent with catatonia. What I like to emphasize is that conversation is inconsistent with catatonia, but simple speech seems to remain in some individuals. So at a loss of what to do to help her and whether to try a different antipsychotic versus another benzodiazepines, we started on diazepam, 10 milligrams IM TID. And within 24 hours, she walked out of her room and asked me where she was. Within 4 days, we had transferred her over out of our unit into the less acute unit. Within 10 days, she was discharged home on a combination of low-dose diazepam and a little bit of risperidone. And 30 days later, she was contacted. She denied the whole thing. She had no interest in psychiatric care. So she had been in Harborview for basically 8 weeks without any talking to anyone catatonic. And we had kind of a dramatic response, and it took a lot of trying. So catatonia, the DSM-5 has 12 symptoms of catatonia. That you have to have 3 of those symptoms to have the diagnosis. I have the little monkey there in the corner to say one of my other catatonic patients, a young man. I was just sort of seeing if he had obeyed some general instructions, and I said, could you stand up and put your hands like this? And he stood up and looked at me and struck this pose like this right in front of the whole team. And so it's like, that's manners, that's very dramatic mannerisms, that's not appropriate. And we asked him afterwards, he didn't recollect doing it several days later when we were talking to him. So catatonia, the frequency of symptoms, essentially any one symptom of catatonia should raise your suspicion for catatonia. That's what's recommended. In the ED, 2 symptoms of catatonia probably are good. 3 symptoms, of course, are what the DSM uses. And in the general outpatient setting, 4 symptoms. Why 4 symptoms in general outpatient? Because generally speaking, catatonia is not consistent with generally being an outpatient. So that's really the bottom line there. Most folks have multiple symptoms. So this is just a graphic showing the number of catatonic symptoms in patients. And you can see is that a majority of patients, if this is just a histogram here, have 4 or more symptoms. This is, of course, partly of the diagnostic, but they have many symptoms of catatonia. This is just the frequency of things. Staring, stupor, mutism, withdrawal are much more common than some of the more things that we think of as being more dramatic, like the Gegenhalten and mannerisms and that sort of thing are less common. So really you're looking at for staring, mutism, basically not interacting with the world.
When you use the word stupor, it makes me think of an encephalopathy. You don't mean to imply that, do you? So an encephalopathy would be with slowed, cerebral rhythms.
So that's a good question. The answer is I don't. The EEG in catatonia is variable, and we don't routinely get it. But it's an interesting question about whether we should be. Sometimes we can't get it because the patient wouldn't comply. That's typical. So I guess it depends. I don't know quite how to answer that question. Yeah.
I'm sorry, just a word up there. What's Mitgahen?
It's going with. So it's the opposite of Gegenhalten. So Mitgahen is basically you kind of move them and they kind of go with you. They kind of follow you. You may take their finger and you lead them across the room, but if you ask them to move, they won't. Okay. So the catatonia, what most catatonia researchers and clinicians agree with is that DSM-5 separated catatonia from schizophrenia, essentially said that the catatonia specifier could be applied to any psychotic disorder, meaning schizophrenia, meaning schizophreniform disorder, brief psychosis, or any mood disorder. It could also be a disorder just due to a general medical condition, or it could be unspecified catatonic disorder, which would be associated with autism or other psychiatric conditions, or if a medical etiology is thought of. We have seen a couple, I've seen several young men who have at least autistic spectrum backgrounds who are catatonic when they're kind of early 20s. This is a long list, I won't even talk about it, but you can find nice lists of all the medical causes of catatonia, and they look very similar to lists for delirium, essentially. They're slightly modified. We do see catatonia fairly frequently in dementia, and that's the one thing I would mention from this list. So if you're looking at comparing catatonia to delirium, this was a case series of about several hundred delirious individuals, and they simply said, well, how many of these delirious individuals have catatonic symptoms? And according to this group, it's fairly common to have catatonic symptoms, and excitement is the most frequent finding, which is clearly the delirious individuals. If 70% were excited in this series, they're defined delirium as sort of an excited delirium rather than a withdrawn delirium. And this is also, I think, is helpful. It's differentiating NMS from catatonia. None of these things should be very surprising, but in a recent meta-analysis of, I think this was over 450 cases in the literature, basically everything that was published, and looking at NMS, diaphoresis, rigor, fever, tremor, laboratory evidence of muscle injury, leukocytosis, that sort of thing were much more, of course, frequent in NMS. In catatonia, you looked at for things like the stupor. Again, we got to the stupor question, how to define that, but waxy flexibility, posturing, negativism. So we see a lot of posturing and negativism, certainly, for catatonia on our unit. Lorazepam challenge, I recommend doing this. The one thing to remember about the Lorazepam challenge is that the data would suggest that maybe 90% of people with catatonia secondary to mood disorders will respond to 2 to 4 milligrams of Lorazepam in the acute setting. But people who have catatonia secondary to psychotic disorders respond at a much lower frequency. First off, they're often catatonic for a much longer period of time before this is tried. That's a little bit of a complication. But they seem to respond less than 50%. And I would absolutely say that this is clinically our experience where folks who have a long history of schizophrenia, who have catatonic symptoms, do not respond in the same way. And then we're stuck with the age-old question, do we continue with benzodiazepines or try antipsychotics or try other agents? And I'm going to skip over that. So criteria. Can I have till 4:30? Is that all right with people, at least? I don't know what time we scheduled to. 5:30.
You got to 4:30.
5:30. Okay. So let's see. I'd like to cover this. I just want to see a show of hands. How many of you have heard of the Research Domain Criteria Project by NMA, by the National Institute of Mental Health? How many have heard of it? Okay, good. I'm going to talk about that because it's very important. So I first learned about this about, 8 years ago when I was writing grants, and someone mentioned it to me, and I had no idea what they were talking about. And I went to the NIMH site, and I said, what is this Research Domain Criteria Project? And basically, I thought it was like finding some intelligence in psychiatry, because it said basically up front, we don't think the DSM is correct, we're going to ignore it. Let's do something different. Now that's basically what they said back then. They've changed their wording. Why have they changed their wording? Because the DSM-5 came out, and Tom Ensel, who is the director of NIMH, in his personal blog, he wrote these words here, that while the DSM has been described as a Bible in the field, is at best a dictionary, creating a set of labels. This is what he said about the DSM-5. He also said it's symptom-based diagnoses, and most importantly, patients with mental disorders deserve better. Well, he meant every word of this. Unfortunately, when it was picked up by the Washington Post and the New York Times, it created quite a stir, because it was picked up as being very much that NIMH was not in support of the DSM-5. He had to kind of go on a whirlwind tour supporting the DSM-5, saying, no, we just have a different way of thinking about things. So the RDOC is, and if you just search RDOC or go to the NIMH site, you'll see this. It's a funding and a new way of conceptualizing mental illness, hopefully to promote better research and more developments. What it is, and you can see there's funding here, is it essentially says, let's not worry about DSM at all. Let's just take all of our knowledge of neuroscience, of psychology, and some of the psychiatry, all those things kind of put together, and think about what are the systems in the brain that control behavior. They have essentially said there are let's talk about 5 gross systems: negative, positive valence systems, cognitive systems, social processes, and arousal and regulatory systems. So if you go and you look at them, they have all listed on the site. What happens is if you click on one of these things on the site, if you just click on negative valence systems, it will give you basically a chart like this. And they'll say, hey, look, on negative valence, there's acute threat, there's potential threat, there's sustained threat, there's loss, there's functional non-reward. And then they'll say, part of these things, what are the genes, the molecules, the cells, the circuits, the pathophysiology, the behavior, self-report, and paradigms. And then you can click on any one of these things and another thing opens up. What this whole idea is this is very much a work in progress. And it's the idea is that they want researchers to submit grants that don't define don't define DSM first and look for biology. They want you to look for either some sort of psychological construct and then try to find the biology, or have the biology and then try to understand how it affects some sort of behavior. Why are the DSM disorders misleading research? I think we all know this. DSM is criteria-based, which is there's just symptom clusters and all of these things. Let's just go through that pretty quick. And I'm going to go through these things that aren't very interesting. But I want to talk about some of the best research that's being done using this. So what the other part of the RDOC does is really says we should be doing bigger science in psychiatry. So this is a group. This paper was just published. And what it is looking, they collected 700 probands with either schizophrenia, bipolar disorder, schizoaffective disorder, their first-degree relatives, and some healthy subjects. And they had them do a battery of tasks, and got ERPs, and got MRIs for structural imaging. This was done at 6 sites, Columbia, Boston, and several others on the East Coast. Huge study. And they eventually said, okay, can we use some sort of factor analysis to differentiate biotypes? And when they put their psychological measures and their ERP data basically into a big statistical model, they essentially identified 3 different biotypes amidst their probands. So they didn't look at healthy controls here, they're just looking at the patients with these disorders. And they identified 3 different biotypes, one with poor cognition and significant sensory motor abnormalities, one with some cognitive dysfunction and actually accentuated sensory motor responses, so seem to be hypervigilant, and then one with no significant dysfunction and mild sensory motor abnormalities. So what does that mean? Well, it really means very little. I mean, this is kind of a theoretical, can we reclassify folks? If you look at this is a kind of a big structure of every patient. Again, these are patients with schizophrenia, schizoaffective disorder, bipolar disorder, and the different biotypes. So the biotypes are on the horizontal axis, 1, 2, 3. Patients are in blue here is schizophrenia. This is purple is schizoaffective disorder. Yellow is bipolar. So clearly the biotypes, if you're given diagnosis, would span all different biotypes. So it's not orthogonal, certainly to that. But there is some proportion, it's a higher proportion of people with schizophrenia up here and a higher proportion of people with bipolar disorder down here. So the biotypes are sort of tracking somewhat with our known diagnoses. And then what they did is they took some of the other data and they said, well, do these biotypes predict better than their diagnosis some of the other neurophysiologic measures? So I'll just show you one example that they published, and I'm sure they're going to publish a lot more in the coming years, is they looked at cortical thickness. So essentially just looking at voxel-based morphology. And what they show is that if they look at biotype, this is the most severe, sort of schizophrenia-like. They had the most differences in cortical thickness, cortical thinning in this case, between healthy controls and people in the biotypes. You can see in biotype 2, there's a little less difference. In biotype 3, there's virtually no difference. And then they looked at their relatives. And I think it's important that the relatives were not part of this grouping. I mean, their data was kept in a box until after they did the grouping. And they can also now start showing that the relatives of these folks actually, the biotypes can actually statistically find differences in their brain. And what they don't show in this figure is when you just look at the relatives based on the DSM disorders, there's no associations. So these biotypes do track better with some neurophysiologic measures, and I'm sure I'll be hearing a lot more from this group as the data comes out. And finally, one last thing is controversies. There's so many controversies in psychiatry. I will not even touch on them, but I want to touch on one, and that is, let's look at this controversy to kind of finish up, and that is mortality and exposure to antipsychotics. It's very popular to think that antipsychotics are very harmful. Well, again, Northern European countries with their massive data sets, they perused the data from 3 million Swedes, and they identified 20,000 individuals who had psychosis, and then they tracked their medication use across their lifetime. And and this is basically what their sample set, and what they found is obviously lots of them used antipsychotics. So this is 4,000 used antipsychotics alone, 6,000 used antipsychotics in combination with benzodiazepines, thousands, and this is their general simple they're looking for, and they're asking the simple question, how does this affect mortality? And I think very fortunately and in a very interesting way, what they showed is here on the very left is antipsychotics, in the middle is antidepressants, and on the right is benzodiazepines, and they look at overall mortality, cardiac mortality, and suicide mortality. And as you just look at these lines, so if we just look at overall mortality, antipsychotics at low dose seem to actually be protective for overall mortality. And even there is a slight increase that is actually statistically significant, but it's very modest. Antidepressants, it's sort of generally flat. And benzodiazepines, you get a real harm, basically fourfold increase in mortality, or fourfold at some situation, I'm not on this chart, but on mortality for benzodiazepines. If you look at things like cardiovascular measures, it's not, again, the same basic data comes out. and benzodiazepines. And suicidality, I think, is actually really interesting, which shows clearly reduced mortality with antipsychotic use. The antidepressant use, I think this is certainly confounded somewhat in that people who are very suicidal and depressed are going to be higher doses of antidepressants, so it's not too surprising to find slightly higher rates of suicidality. And then benzodiazepines have very high rates of suicidality and suicide. So I think what this hopefully shows pretty clearly is that antipsychotics are not overall, they're actually associated with better outcomes long-term in whole country population studies.
But that's not in the neurology population that is being used.
No, this is psychiatric population. This is folks with psychosis, exactly. This is not the dementia population, or there's no comment on dementia or autism or all the other things that get mixed in here. So this is definitely the people identified with primary psychotic disorders, who had years of exposure, of course. So this is my overall kind of conclusion slide. Cannabis is bad, and I'm sorry if I seem kind of old school there, but from a psychiatric perspective, we see it really inducing psychosis and certainly is not helping probably any psychiatric disorder. Ketamine's use is very, very unclear. I think ketamine itself, I highly doubt will ever be developed as a treatment in psychiatry, but a metabolite like H and K absolutely could be really exciting. Catatonia, which I think is underappreciated, and we should all be keeping our eyes open for it more often. Criteria is pretty ugly right now, exactly what's going on between DSM and the RDOC. And I think even in the last 6 months, there's been about over half dozen commentaries by high-level people really arguing back and forth whether this is good or bad for the field. And I think controversies are great. I kind of skipped over a couple of the other ones about sort of whether long-term effects promote psychosis, which we don't really have data for. But I think the controversies are great, kind of keeps us all honest. So I hope you all someone got something out of a little something out of everything. So that's 5 new, or maybe more than 5 new things in psychiatry.
So let's, we'd love to ask a few more questions.
Absolutely, yep. Mm-hmm.
Just had a question that you did with that last study about comparing benzodiazepines and
Yep.
If the cause of suicide mortality was then obviously benzodiazepines having a lower, LD50. When you're providing someone with the drug that you potentially use to kill them.
That's right. So the overdose is caused by benzodiazepines. And actually the data was not there because they didn't necessarily have cause of death in the medical record. Yeah. Yeah.
So I'm totally thrown into a state of confusion about catatonia. So catatonia is a descriptive term, but it's also been thought of as a disease, a psychiatric disease, very pure, very specific. It's a person who's fundamentally got a completely normal nervous system, and for psychiatric reasons, obviously interacting with the nervous system, they're not impairing consciousness, not impairing alertness. You describe that woman who's wide awake, watches you, gets up, asks for food, et cetera, very unlikely that this kind of a woman with perfect vigilance is going to have abnormal brainwaves and think the way that we think about a patient with an encephalopathy. But you seem to open the door for the idea that in psychiatric parlance, catatonia may be a disease with major alterations in brain function. To the point that you'd have moderately generalized slowing of your EEG.
Yeah, so I can't speak on what would happen to the EEG. The data just isn't there, so I don't know. I'd be very interested in knowing that. The current theories, one of the slides I skipped over, the current theories of catatonia in a psychiatric population is basically hyperarousal of emotional circuits, sort of like ventral limbic circuits, basically overwhelming the cortex. Why? Because there's only a couple of imaging studies that suggest there's overactivation of orbital frontal cortex, amygdala. And if you ask patients when they come out, most people don't remember being catatonic, but those who do will often say that they were fearful. And they will often report sort of illusions, that everyone looked like an alien. I thought you were coming in to do experiments, and I just couldn't answer you. So it's a mixture of sort of a misperception and also very much a delusional, paranoid delusion. So there's a thought that the activated catatonia is sort of a fight or flight response. And what we'd say is the retarded catatonia is more of a freezing response that would be typical of emotional circuits. So really, it's sort of overactivation in emotional circuits, and really that's what catatonia could be, is a little bit about freezing and not responding. I will come back to that. I agree with you. The thing that's most important for me to differentiate catatonia from delirium is attention. I'm always looking for attention. And if someone is sort of like just kind of randomly looking around, talking gibberish, that sort of thing, then it's probably not catatonia. It's probably delirium. But people who are catatonic will seem to be aware, but you feel like you're kind of through a screen. And I had a slide that I skipped over where I really, delirium appears much more like intoxication. Catatonia appears like the person is sort of on a different world. They're just not quite there. Like they see you, but you've got like a big wall between you and them that's preventing them from really interacting appropriately with you. So I agree, it's not a disorder of attention, or maybe not even consciousness, but of sort of reality testing and overall emotional arousal.
If no one has bothered to take a group of catatonics in a way that's not painful and wouldn't require extensive recording, just done simple EEGs, they certainly ought to do that.
We should.
It's
it's been done, but not in a systemized way. There's certainly case reports out there. Yeah. Yes, it would be a good thing to do, to know about this. And given, we can't even get EKGs on most of our catatonic patients, unfortunately, so getting EEG is very difficult.
Yeah, they're so negative.
They walk away. We have a woman on the unit right now who has not spoken to us in a couple of weeks, and she'll stand in the corner, and when you approach her, she'll stand until you touch her, and then she'll violently attack you. And so we can't even get any EKG on her, never mind anything else. So this is this in a different world. We can't communicate. She won't. There's nothing to negotiate.
What's the prognosis?
For mood disorders and catatonia, very good, actually. So about 90% do respond to benzodiazepines, and if they're treated for their mood disorder, can never have a catatonic syndrome again. Schizophrenia is and psychotic disorders is a different camp. It's much more chronic, much harder to treat. Even when you do treat it, you're left with a very psychotic individual. I've certainly had several individuals that we treat with high-dose Lorazepam, and we use up to 12 to 16 milligrams of Lorazepam a day. I've gone up to about 20 TID, IM diazepam and stopped there. The problem in schizophrenia is you do this and you might induce some interaction and some normal behavior, but they become very psychotic. And then you have to also treat antipsychotics, which is, again, can make it worse at times. So, yeah.
So I'll maybe ask a bit of a naive question here, because it seems like the DSM is casting a very broad net over catatonia.
Mm-hmm.
So for a patient who's been in an outside ED for 6 days boarding, and then involuntarily admitted to a psychiatric service, and then doesn't respond to her providers, is there any diagnostic way to tell that from just general oppositional defiance? Right.
So the psychiatric ICU is all involuntary. People want to leave. We see people who want to leave every day, basically most of my patients. People who want to leave don't just stay mute for weeks on end. They lie to you. They say they'll take their medications and leave. They'll figure out that they don't have to tell you anything. And all of that gets them out of the hospital. And I actually tell them that. All they have to do is lie to me and they can basically get out of the hospital. But if they're able to lie, that's the question, right? If they're able to say, hey doc, yeah, I'm fine, I'm gonna be safe, not hurt anybody. But they can't do that. They can't even put that together. And if you want to say, was that oppositionality, what is that? What causes that lack of reality testing to the point where they cannot even negotiate that basic concept that it's really pretty easy to get out of here? And also, when I think of these catatonic patients, they're very The woman on the unit right now, when I started the IM diazepam, her response to it was to urinate and stool all over the place. And it's just like we talk about this is what animals do, quite frankly. It's not really, that's not what people do, generally speaking. I've told her very many times, if she talks to me, I'll release her from the hospital. Not a word. So, yeah. I'd love to do it, can't do it in Washington State. It's because of the laws. So if you were somewhere else besides Washington State, we'd probably have more ECT for Catatonia. And it's very effective. But getting ECT in King County when someone is refusing it is almost impossible. If they have a guardian ad litem and a history of response to ECT, like someone has a history of major depression or bipolar disorder and has responded to ECT and has some sort of agreement, even though it's never legally binding, but if they do some sort of advanced directive, you can do that against their will. But getting someone who says no to get ECT in King County is almost impossible. Not impossible, there's about a case a year that we are able to get through. Yeah.
And it's my understanding, at least in one case that we had, it's easier to get ECT for catatonia secondary to a neurologic disorder than a psychiatric disorder.
Probably true. I don't know that for sure, but that would make sense.
We just had one patient on our service.
Yeah.
I have to say the neurologic.
Yeah. I mean, that's true. And also, if they go down to Pierce County and to Western State, it's easier to get compelled ECT.
So that brings us back to the issue of trying to use the word catatonia. Maybe descriptive, but I mean, I don't consider that splitting hairs. To my mind, catatonia you're talking about has nothing to do with neurologic catatonia.
It's a good question. I don't know the answer to it, but yes. If the DSM has opened it up that catatonia is a descriptive term for many etiologies versus a single etiology, yes.
Can I question on one more point? You talked about ketamine as addictive.
Yeah.
For a long time, the definition of addiction required tachyphylaxis, that the drug was less effective the more times you use it. My understanding with ketamine, that's not true, nor do you have crystal clear withdrawal symptoms.
Yeah. So the DSM-5 is really, and I think most of the field has moved away from the physiologic sort of definitions of addiction to the more the psychological definitions of addiction. Yeah.
That was terrific. Thank you so much.